Hello, everyone. This is Enrique Bakemeyer with Healthcare Business Insights, and I'd like to welcome you to today's sponsored webinar, Roundtable, presented by PMMC, How Healthcare Providers Are Preparing for the New Age of Pricing Transparency in 2019. As noted on slide 2, you will have the opportunity to ask questions during the webinar by typing them in the space provided in the open Q&A field on the right-hand side of the screen. We will take a couple of brief pauses to field questions on slides 17 and 22, and finally at the conclusion of the webinar. If you need assistance at any point during this webinar, please call our client engagement team at 888-700-5223 for personal attention. As always, today's program is being recorded, and registered attendees will receive a copy of the presentation by email within the next couple of days. Here are the learning objectives for today's session. Describe how organizations are responding to CMS price transparency requirements. Evaluate different approaches for publishing standard charges in terms of patient friendliness. And analyze potential impacts that price transparency requirements may have on the healthcare industry in the next few years. As a reminder, to receive CPE credits, you must answer the 3 in-webinar polls during the event. The first poll will be on the next slide, and the other 2 will coincide with the Q&A breaks on slides 17 and 22. So before we turn it over to our panel for today, let's spend a few minutes reviewing some HBI research on the subject of today's webinar and also launch today's first poll. What is your time frame for adding patient cost estimates to your hospital's website? The answers are, we are already doing this today, B, within the next 6 months, C, within the next 6 to 12 months, or D, we have no plans to add patient cost estimates to our website. Again, that question is, what is your time frame for adding patient cost estimates to your hospital's website? The answers are, we are doing this today, within the next 6 months, within the next 6 to 12 months, or we have no plans to add patient cost estimates to our website. So price transparency and the CMS rules about posting standard charges, related topics like patient estimates, have all been very hot topics for our members as 2018 drew to a close. Some of you may recall that PMMC presented a webinar on these topics in October, and that same month we here at the Revenue Cycle Academy also presented a webinar with some peer perspectives on pricing transparency and CMS's rules about posting standard charges. Those were some of our best attended webinars of the year, and we have been continuing to get questions from you about the approaches healthcare providers are taking to publishing standard charges and offering patients estimates of their out-of-pocket balances. So you've spoken, you've said you want to hear more about these best practices in this area, and we're happy to oblige. And of course, a big thanks to PMMC for helping facilitate today's roundtable. So to be sure, it's fair to say that I wanted to review, for those of you who were not able to attend the Revenue Cycle Academy webinar in October, some of the registration poll results that we had from that webinar. So as I was saying, it's fair to say that the average patient is not going to know what to make of a hospital charge master, so our poll found that over 3/4 of respondents, 76%, said they were going to provide patients education on how to interpret the posted charges in addition to posting the charge list. We will explore some examples during today's program, but some common approaches were to include a disclaimer with the charge list that the charges don't reflect what the patient will owe, and to include information about why patient charges may vary, such as differences in insurance coverage or the supplies used. Some organizations also encourage patients specifically not to rely on published charges, but to call in for an estimate. Perhaps not surprisingly, there were some mixed feelings about how helpful posting charges would be, with only 18% saying without qualification that it would be helpful. We had also asked about what options patients were being given in terms of being able to obtain estimates of what they will owe. Over-the-phone estimates remain overwhelmingly common, and in fact, that was the only option available at 45% of respondents' organizations. We are seeing more organizations offer online options for patients to obtain to obtain estimates, and we will be reviewing some examples of what those organizations are offering in today's session. There's some additional data points about estimates from our October webinar, and I did want to note that the data points you see here were questions that were submitted by members. So please continue to submit your questions, which will help ensure that we are collecting the data that is most meaningful to you. And as you can see, we may be able to answer some of these in our Revenue Cycle Academy registration polls. The data you see here reflects some specific process and policy questions members have had regarding how long estimates are considered valid, whether estimates combine hospital and professional charges, and how much organizations are refunding. And finally, I wanted to let everyone here know about a couple of upcoming events. First, our 2019 Spring Member Retreat is a little earlier than it was in previous years, and it's at a new location. It will be held on March 25th through the 27th in Boston, and as a reminder, there is no registration fee to attend. Our retreats tend to be more intimate, giving attendees great opportunities to network with each other as well as presenters and panelists. So if you're interested, please go to our web portal for more information. And also, in 2 weeks from today, will be our next Revenue Cycle Academy webinar on the topic of preparing for the Medicaid expansion. We'll be featuring a couple of our own internal HBI experts, Beth and Andrew, and that webinar will be, again, 2 weeks from today, January 30th at noon Eastern. That's 1 hour earlier than we typically run webinars, so please take note. So without further ado, I'd like to introduce our panelists for today's roundtable session, starting with Greg and Brad from PMMC, who, as you know from previous webinars hosted by PMMC, have been great speakers and great presenters on the various topics that we have at hand. At this time, I would also like to introduce, or actually to allow some of our other panelists for today to introduce themselves, starting with Jackie from Metro Health. Go ahead, take it away, Jackie.
Hi, thank you. My name is Jackie Wolno. I'm the Director of Revenue Integrity and Professional Coding for the Metro Health System in Cleveland, Ohio. I apologize for my voice. I'm combating a bit of a cold. I'm very excited to talk to you guys today. We at Metro Health are very passionate about pricing transparency, so I'm excited to share with you some of the things that we've done and very interested to hear from the rest of the panel as well. Thanks for having me.
Thank you, Jackie. And now Susan
Downey. This is Susan Downey. I'm the Manager of Pricing and the Charge Master with Virginia Mason Medical Center, located in Seattle, Washington. And we also are very passionate about pricing transparency. We've been posting our Charge Master for a while now before the regulations, so we are also very interested in seeing what everyone else is doing and how they're presenting it. Thank you also for having us.
Thank you very much, Susan. And now Megan.
Hi, my name is Megan Windler. I am the Director of Revenue Integrity at Eskenazi Health currently. And with the Charge Master and some of these changes, I find them very exciting because it is also about the financial health of our patients. So I'm very excited as well to hear what other organizations have done and the progress others have made with this new mandate. Thank you for having me.
Thank you very much for coming. And finally, I'd just like to note here that Cabby Thompson of Texas Children's Hospital was originally scheduled, but unfortunately was not able to attend today's webinar. However, she did supply information that will be presented today by Greg and Brad at PMMC. So for our first panelist question, I'd like to start actually by directing it to Virginia Mason. How did your organization respond to CMS's deadline of January 1st for the pricing transparency requirements to electronically post your standard list of prices? Susan.
So we actually developed a website specifically for this regulation. We already had the files available due to the current ACA regulation, but we did have to convert them to a machine-readable format. We had them in a PDF format. So our organization is an integrated health system, so we published both our hospital and the professional charge masters. We did that based on feedback we heard during one of the open door forums. For the DRG file, we chose to use the median charge. I felt that that would be more in line and would take care of any outliers that might show up as far as the DRG. In addition, because I felt it would be more helpful, we chose to publish our outpatient surgical medium charges as well. Also, the web page directs the patient on how to obtain an out-of-pocket estimate, financial assistance, and there's also a link to email the charge master department if they have any questions.
All righty, thank you very much. For our next panelist, Jackie at Metro Health, how did your organization respond to CMS's deadline for posting for pricing transparency requirements to post your standard list of prices?
Yeah, so as I had mentioned before, we've always had a passion at Metro Health for pricing transparency. So we were happy to see CMS take steps in the direction of making hospitals be more transparent, but we are very well aware that posting a charge master online is maybe not the step we were hoping they would take. And we're concerned that patients would be a little bit more confused. So we also created this page on our website that you see here that does have a link to our standard charges by DRG, which we also used an average of 6 months. We do have our full hospital charge master there as well. But the very first link that we have provided is actually a list of frequently used hospital services. So it's a more condensed version that is in a PDF reader-friendly format that hopefully patients will be more likely to pick that and be able to actually understand it. Of course, in addition to all of that, we've included an area for convenient online bill pay, an area to schedule a consultation to talk to a representative, and then a link directly to our cost estimator, which is up in the bottom right corner.
Thank you very much. And next to Megan, how did you, well, the question's up there, so please provide your response. How did you respond to the CMS January 1st deadline?
Sure. As with many other organizations, we wanted to make sure we met the requirement, so we were compliant with the new regulations. And we are a publicly owned facility, so we do pride ourselves in being transparent as possible, so this did push us in that direction. Again, we did meet our deadline, but we continued to post pricing based on the previous requirements as a result of the initial pricing transparency mandate. So we kept that information up there, not to change too much for our patients, and also to ensure more common prices are still available to our customers, in addition to the new requirements established by CMS. The first part of the process, as we went through this change, was working with PMMC to ensure our pricing was more strategically aligned with our organizational goals and mission, which did result in some reduction, but we felt more comfortable in posting those prices and working with them. Additionally, working through this, we had to think very methodically to make sure that there was a way to help guide our customers when accessing this information. Because when you access the information and open it up, it's a whole different story for somebody who doesn't work in the healthcare industry. Also, since CPT and HCPCS codes are copywritten, we needed to make sure to scrub the data. So we provided a way to operationalize this process internally, kind of like a crosswalk or a primary identifier for charges. And we did this by utilizing our actual charge codes. We have also scheduled and continue to schedule standing meetings with members from various revenue cycle departments and clinical leadership to provide training as an attempt to be proactive in addressing inquiries from our customers, so making sure our frontline staff are also prepared. Because guidance and education are going to be the number one thing coming from this as well. Although our disclaimer is clear as to what the pricing represents, we do still expect questions. And we're working to automate this process so we can have real-time updates on our website, which we do have functionality to do that through Epic. And again, I just reinforce the fact that it's important to provide education and remain transparent with this process internally and externally.
All right, thank you very much. And for the final panelist, this will go to Greg, who will be responding for Texas Children's. How did your organization respond to CMS's deadline of January 1st to post your standard list of prices?
Great, thanks, Enrique. And Ms. Thompson did share that Texas Children met the January 1st deadline for posting their charges, and they also had an internal deadline for deploying an online estimate tool. And they chose to expand on their current practice of providing patient estimates prior to the date of service with more of a self-service estimation tool online, and to provide information to really help parents understand why children's hospitals can't necessarily be compared to general hospitals. They also provided a link to their quality data. As a point of reference, in just the first couple of weeks of having both their charges and their estimation tool online, Texas Children has seen their CDM file opened and viewed by individuals approximately 70 times thus far. They've also seen over 150 patient estimates being generated, and this is very consistent with what their expectations were in providing the link for the estimate first, with the list of Texas Children's standard charges lower on the page. It's interesting to note that with the 70 CDM file request views that they did have, they found approximately 10% of those views were from other hospitals or competitors that were linked or tied back based upon the required email address. They do require individuals to enter their contact information before actually viewing the file. And I think these are great example statistics of how hospitals need to be thinking strategically in the types of insight and analytics that you should be tracking now that we're posting charges and that information is available online to the public.
And then going beyond the examples that our panelists just shared, PMMC did some additional research on approximately 80 hospitals across the country to find out how hospitals generally had responded to the mandate. And what we found was that 87% of hospitals that we identified have met the requirement, with the data being relatively easy to find, and we define that being able to get to the charge master in 5 clicks or less. We also found that 38% also provided the required list of prices by DRG code, and that 88% of the charge master files that were posted online appeared to include pharmacy. And as we now know, or learned right before January 1st, DRG information and pharmacy information is part of the mandate. Now, going beyond CMS's requirement and being proactive, we also found in our survey that 86% of hospitals included a phone number to contact for more information, and that 10% actually do have an online consumer estimate pricing tool. Now, from 2012 to 2017, hospital revenue contributed to the patient balance after insurance, and that actually increased 88%, so it nearly doubled in 5 years. So we really need to start embracing the fact that the patient as a financial class is becoming a critical payer group today. Hospitals do not need to wait for CMS to mandate changes that are occurring in front of us. We need to continue to adapt our workflow and systems to let our consumers know how much they are going to owe, as well as provide an easy means for collecting it.
So as we did our research, a few additional things that we identified as we were viewing different websites, how hospitals are posting the information. A real common theme that we saw that were being tied to the chargemaster files was educational information. More specifically, really explaining the role of charges, explaining payer allowables or the expected reimbursement, explaining what the patient owes, as well as disclaimer information. And this disclaimer information really helps reinforce and support your pricing message. As an example, it should call out key items such as the hospital providing price estimates for many common services with a phone number for a call-in to obtain that particular estimate. As Brad noted, we found in our survey only about 85% of the hospitals actually had the phone number, so we think that's a critical piece of information as we're trying to educate and bring the public current with the information that is going to be available for them. A more creative example that we found was a 90-second video that actually explained, as an explainer video, the difference between charges and the out-of-pocket patient responsibility, or their cost. This particular hospital required the patient, the consumer, the individual, if you will, to watch the entire video before allowing them to access their charge file. We thought this was a really creative way to ensure that the hospital was educating their patient and their patient community. As we went through our survey process, another piece of interesting information that we found was the number of hospitals that also included an acknowledgement form to ensure that they were gathering key contact information, such as the individual name, email address, if you will. And this can provide you with some real critical insight into who is requesting your charges. And it can also be a means for your IT department to also include simple checks like "I am not a robot." This is a great idea or way to reduce the number of organizations, if you will, that are just automatically downloading your charges. We only saw this particular item in really less than 5% of the websites that we did survey. So this would be something that you may want to take back to your IT departments to incorporate as you go forward. The last piece is just to note on that checklist, this was a great example of message reinforcement. Before the hospital allowed the individual to actually see the charge information, they had to go through and actually check 6 or 8 boxes, just acknowledging their understanding of charges, what charges relate to, contact information, etc.
And also in our market research, we decided to look at what exactly was included with that CDM file. So what we found was that most hospitals posted their CDM file in either an Excel or a CSV file. We did find a few instances of a text file like the one you see here. And I think we would argue that that type of format is just very difficult to read, and it makes it more difficult for the patient to consume the information. So when we looked at what was included in the ChargeMaster file itself, we found that of the 87% of hospitals that did post their ChargeMaster, all of them included both the charge description and price. So that was the most common theme we saw. So while posting this information in a machine-readable format meets the mandate, it's also worth pointing out that if a patient really wanted to compare charges across different hospitals, the CPT code would be the most valuable identifier. In this case, we found that only 14% of hospitals actually did include the CPT code. Now, this could also be due to the hospital not wanting to make it too easy for competitors to compare charges. So there might be another reason behind that.
Alrighty, sounds good. And with that, we'll take a pause for our first scheduled Q&A break. First, we'll share the results of our first poll. As a reminder, that question was, what is your time frame for adding patient cost estimates to your hospital's website? The results of that poll were 60% said that they were doing this today, 19% said they had no current plans, 16% said within 6 to 12 months, and 4% said within 6 months. So now we've just launched our second poll, and that question is, how are you planning to adjust charges for your next fiscal year? The answers are, increase charges using a standard/internal process, decrease charges using a standard internal process, engage a third-party consultant or expert for a more strategic approach, or no plans to adjust charges. Again, that question is, how are you planning to adjust charges in your next fiscal year? Increase charges using a standard process, decrease charges using a standard process, engage a third party for a more strategic approach, or no plans to adjust charges. And with that, we'll begin with a couple of questions. In fact, we've got one that just came in the QA here. Actually, this came in while Megan was talking about her answer. And the question is, did you consider a pricing review prior to posting to align or adjust your fees? Sorry about that. So did you consider a pricing review prior to posting to align or adjust your fees? Maybe we'll start with Megan, and then we'll go to the other respondees as well.
Yes, actually, yes, we did. We worked with PMMC in conjunction with Eskenazi. We worked together to come up with some strategic review of our current pricing and our pricing models that we had in place to, do some comparisons, again, making sure that we're in line with the market, that, our pricing is fair for our patients. Again, we are a publicly owned facility, so that's very important for us to ensure that, we are priced appropriately. So, again, yes, we did have a strategic review, and we worked with PMMC on that.
All right. Susan, did you want to offer thoughts on that matter?
We didn't do it as part of this mandate. That's a normal process of our pricing each year. So we already use PMMC to do our pricing, and part of our yearly pricing review is to look at the market and to make sure that we're in the market and where we want to be. So as part of this mandate, no, but as part of our yearly process, yes.
All righty. And Jackie, did you consider a pricing review?
We did, and my answer is pretty similar. We do it regularly anyway, so we had just completed that as part of a different initiative, but definitely took into consideration where we were in the market and where our price point was prior to posting everything online.
Great. Okay, here's another question. How did you train your revenue cycle teams to respond to patient questions about standard charges, the charge master, or related topics? Maybe we'll start with Jackie on that one.
Sure. Questions as it relates to charges are not new, at least for us. So thankfully, our customer service staff has already been equipped for quite a while with scripts as it relates to what the difference between a charge versus an allowable is. We haven't seen a huge uptick in those questions since January 1st. However, they are armed and ready should the volume increase.
All right, terrific. How about Megan?
Yes, so we actually, to go along with Jackie, we have a fabulous customer service department that we've worked with to address those questions and also begin tracking to understand, who these inquiries are coming from, who are the most interested parties with the pricing. Again, this is nothing new when it comes to charging and pricing. There have always been questions around that, so we've had tools in place. But in preparation for this new mandate, we wanted to make sure that we are sharing all the tools that were also being provided to the patients and are currently in the process of providing that education, not only to customer service, but, the clinical departments as well. So if they do get questions, they're aware of this new regulation and aware of what we have out and available to our patients.
Great. And then finally, Susan, did you have any thoughts on that question?
My response is very similar to Jackie and Megan. This is nothing new. We have scripts for our patient financial services that help with these types of questions that come in, and they're well equipped to answer these types of things. If it gets to be really in-depth, then they send the questions on to me to be able to finish off answering. But we have very excellent customer service people, and they're able to handle them. We haven't seen a large uptick either in this. The most questions I've seen is actually from people who are becoming aware of this regulation, panicking, asking me if I've heard of this regulation. So from within our organization. So I think we're well equipped to handle it.
All right, great. We'll take one more question here. Did you make adjustments to your business office call center staffing in anticipation that publishing standard charges would increase call volumes? Let's start with Megan this time.
At this time, we have not increased staff volume or staffing because of this new mandate. We don't have the information to justify that at this point in time, but again, it's something that we need to track in order to make sure that, we have the appropriate FTEs in place to address.
Okay,
and how about Susan?
No, we haven't made any adjustments either. We're monitoring the situation, and if it becomes apparent that that's necessary, then we would make the appropriate adjustments. But right now, we're just keeping an eye out on the situation.
Okay, and finally, Jackie, did you make any adjustment to staffing in your call centers?
No, my answer is very similar. At this point, we haven't seen a need, but should that need arise, we would adjust accordingly.
Okay, great. And I think that we'll call that Q&A session for now, and then we'll have another one on slide 22. So if everyone else has questions, please continue to submit them in the Q&A feature on the right side of the screen. For our next panelist question, let's start with Metro Health. What is your hospital's biggest concern now that standard charges are public?
Far and away, our biggest concern is public misconception, which I would guess is probably a lot of our concern. We would hate to see a patient make an assumption that they cannot afford to have a necessary service performed based solely on a gross charge. What we really want is for our patients to understand that looking at charges alone is not going to give them the answer that they're looking for.
Alrighty, and how about Megan? Same question.
Sure. We echo the same concerns that Jackie and her organization outlined, is the misperception of what this information means to our patients and how they're translating that. It can be a bit confusing for those who do not work within the healthcare industry to interpret this information. And as many of us are aware, we have to consider payer contracts, self-pay discounts, cash services, what's under a grant, and while also understanding the various billing models in addition to, okay, well, now we have a price estimate tool and we have the CDM pricing. So with all these different considerations, and then the new CMS pricing transparency, it's a lot of information, but, again, our patients and customers understanding that. And again, to Jackie's point, is we want to make sure our patients get cared for, and we don't want patients turning away because it is something they don't think they can afford. That would be our worst case scenario.
No, thank you very much. All right, Greg, how about Texas Children's?
Yes, Caveat shared very similar thoughts to Eskenazi and Metro Health that their biggest concern is misinterpretation of the charge master by patients who might think that it's really their out-of-pocket expense. And this ties back to their focus on having the right educational message and incorporating the right tools so that patients can get more of an estimate of their true out-of-pocket and not misunderstand or get confused over a charge item that really isn't relevant to what their true out-of-pocket expense is going to be.
And I'll add to the concerns about the public misperception, and we've already seen a good amount of media coverage on this just in the 2 weeks since the mandate was official, both on the national and local level. National outlets like CNN, Modern Healthcare have started to pick up on this and have been somewhat critical of the information being posted. Modern Healthcare actually took it a step further and called out some specific hospitals that did not do a good job, at least in their opinion, of displaying the charge master information. And I think this was the type of response that a lot of us were concerned about. And as we look at it on a local level, this is probably more impactful for individuals on the call today around that local media coverage. I know here in the Charlotte market, I've already seen several articles on social media that call into question some of those higher priced commodity items. And we all know how easily and quickly that information is shared today on platforms like Facebook and Twitter. This is an example of a news outlet in Louisville, Kentucky that compared the 4 major hospital groups in the market and really focused on the large pricing discrepancy on some particular procedures and treatments. And I think the takeaway from this is that this is something that's very preventable and manageable by just taking ownership of doing those local charge comparisons and making sure that those charges are in line with the market so that your hospital isn't called out in local media coverage like we saw here.
Alrighty, and then for our next panelist question, let's start with Virginia Mason. How do you see price transparency affecting your hospital's charges?
So right now I don't really see it impacting how we set rates. Since we already use market data to set our current rates, we also use our cost and our contract rates, and we use PMMC to help us set that. So our pricing is already competitive with the market, and unless there's a huge shift in the market, we probably wouldn't make any big changes.
Righty, and then Jackie, how about Metro Health?
I concur with what Susan said. Everybody knows there's a lot of components that goes into pricing a service, and market rates is just one component of that. But Metro Health has been posting some of our charges online for years. So really, pricing transparency has always been a part of the equation for us, and I don't foresee any major changes happening unless, as Susan mentioned, the market should happen to shift suddenly.
Yes, and Greg, I believe you have some info from Texas Children's.
Yes, Cabby had shared that they do not think that merely posting the charge master will prompt a change in the industry or at their organization as it relates to changing their charges. Making changes to their prices or the charge master price is not really going to change the true cost of health care. It's their view that it's not really going to help the average consumer understand the cost. It will likely lead to more confusion. They see that the charge master really being a symptom of a larger problem that can't be fixed overnight, but they believe that there is a longer-term solution, and that evolution process is just beginning now.
All right, and then for our next panelist question, I'll first direct it to Megan. How do you see price transparency affecting competition in your market, and how are you responding to it? Megan, did you happen to mute your phone?
Oh, sorry. I still believe that it's going to be about patient care at this point, and maybe not so much of competition from that perspective, but optimal patient care that the patients are receiving. Yes, the pricing transparency and the prices are out there, but again, just to kind of echo what Jackie was saying earlier, the prices have been out there for many years, and contacting organizations to get pricing information, that's been available. So I don't see there a lot of competition coming our way, at least. Again, we're a publicly owned facility, so we're a little bit different. Besides, the charge master not being a direct reflection of what the patient will actually be charged and or actual out-of-pocket expenses, until a lot of that gets ironed out and there's more stringent guidelines around this transparency rule, I think that's where we would possibly see a shift later on.
All right, thank you. And then Susan, how about Virginia Mason?
Like Megan, I don't think having everyone publish their charge master is going to impact competition. Most hospitals that I know of have published some sort of fees somewhere on their website, and most patients aren't going to understand the charge master and what it means. The only way I believe price transparency in any form is going to impact competition is if there's an actual tool out there that can compare multiple organizations, and what it needs to compare is their actual out-of-pocket across those multiple organizations, and not just the facility fee or whatever it needs to be for the entire procedure or whatever they need to have happen. And until that happens, I don't really see this affecting competition, at least in our market.
All right, thank you very much. And with that, we'll pause for our second scheduled Q&A break. First, we'll share the result of our last poll. As a reminder, that question was, how are you planning to adjust charges for your next fiscal year? 42% of you said you will increase charges using a standard process. 3.5% said you would decrease charges using a standard process. 44% said you would engage a third-party consultant or expert for a more strategic approach. And 10.5% said no plans to adjust charges. So with that, we'll launch our final poll for today. Given that patients ultimately prefer a total cost of care estimate, including physician costs, what is your confidence level in providing this to patients in 2019? The answers are very confident, somewhat confident, not confident, and those are the three answers. Again, that question is, given that patients ultimately prefer a total cost of care estimate, what is your confidence level in providing this to patients this year? Very confident, somewhat confident, or not confident? And with that, we'll go to the Q&As that have been coming in. This one comes from Kathy. For those who provide price estimates, is the estimate a complete cost of care estimate? So, for example, does it include physician fees, lab, and radiology, which of course is pretty handy considering the polling question that's going on right now. So let's start with Susan on that one.
Yes, our estimates contain all of that. We're an integrated system, so all of our physicians, radiologists, anesthesiologists, everyone is employed by our organization, so it makes it simple for us to be able to do that. So our estimates are a complete estimate of care.
All right, thank you very much. Now, how about Megan? Are your estimates a complete cost of care?
No, currently our estimates are not a complete cost of care, but we are in the process of reviewing that and getting we have a system to implement that. So we just.
Alrighty, and finally, oh, sorry, go ahead.
No, you're fine. We're just in the process of getting that implemented.
All right, terrific. And then finally, Jackie, same question.
For the hospital side, yes, everything is included. So lab, radiology, any ancillary services are part of the estimate. I can't say that we have professional lumped into that today, but at least on the hospital side, I am confident that we are providing everything.
All right, terrific. Another Q&A that came in from Leslie. How often do you plan to update the CDM? Annual as required or more often? Let's start with Jackie on that question.
That's a good question. I don't know that I actually have a plan or there's no calendar that I refer back to. We are constantly looking at it. So as things change, either with payers or with situations or with the market or with you name it, we will make adjustments to our charge master as needed. We always look at it a big once-over at the end of the year when we're adding codes and deleting codes, but the scheduled maintenance, if you will, of that charge master and making appropriate changes is forever ongoing.
Very good. How about Megan?
So I can answer this two different ways. One, yes, we always do an annual strategic pricing review. Again, we worked with PMMC this year and hope to continue that relationship. But we also, within the system, to update the CDM from pricing transparency, the rule mandates it annually, but we do have the possibility and are working on a more real-time update into the system. So if there are any changes or additions or new procedures that get added to the CDM, that information is readily available to our patient or anybody who's looking at our pricing information.
Very good. And then Susan, how about you? Do you plan to update more than annually?
I don't plan right now to update more than annually unless we do a mid-cycle price update. So our plans right now are just annually.
Alrighty, and here's a question. We'll take one more here before moving on. As a reminder, there'll be a final Q&A break at the end. But one question here from Jory. How can patients find their cost if they don't know their DRG? Let's start with Jackie on that one.
So that is really a good question. And the answer is you can't, right? So for estimator tools that can provide DRG level information, they may be able to guide the patient to the appropriate DRG. These are the instances, though, where we really want to talk to our patients because, honestly, they might not even know exactly what the procedure is called that they're having. So there's a lot that goes into it, and we really want to have a personal connection with those patients to help them understand their individual impact.
Alrighty, how about Susan?
Well, I think Jackie said it perfectly. We want to have a conversation with them. It's very difficult for a patient to know what to look for because the wording on those DRGs is not very helpful. So a personal conversation with them, we want them to call in and to assist them into finding what they need to look for.
And finally, Megan, do you have any thoughts on this question?
The same as Jackie and Susan. We definitely want to talk to the patients. Most of the patients, if they're calling about a DRG, they have no idea what a DRG is. So having that, one-on-one connection, that personal connection with the patient is important so we can help and support them and provide what they're looking for. And if by not doing that, we obviously create any, unneeded stress on the patients who are already looking to get procedures done. So definitely about patient satisfaction and customer service.
All right, thank you very much. As a reminder, we'll do one more Q&A at the end, but for now, let's move on. And Greg, from a broader perspective, what do you think will be the next set of CMS price transparency requirements?
Yeah, great question, Enrique. In looking back over the last 6 months or so of interviews with CMS and their frequently asked question document responses, they've published 2 of those. I believe they've been very clear with their direction, and they expect the industry to lead this transformation and really not direct or not wait for CMS to dictate what their expectation is going to be. As you can see from the comments online, these statements are from Seema Verma, who is the CMS director, and they have been very clear, and she has continued to reinforce the message that posting charges is truly the first step. Their goal and their intent with these actions and these requirements are really to make pricing transparency actionable. When we keep in mind that nearly 21 million Americans in 2017 had a high deductible health plan or a healthcare savings account, that's a lot of individuals, and that number is going to only continue to climb as we move forward, as our country tries to grapple with how to lower and contain the growth of healthcare costs. Patients' financial responsibility is tied to, as many of us have noted on the call today, the insurance carrier's allowable of that contracted rate, if you will, the patient benefit information being the copay, coinsurance, the allowable, deductible, remaining out-of-pocket information. CMS's requirement to really post charges should be seen as a means of increasing competition from the standpoint of helping patients really understand what's the most affordable route. And CMS has noted on several occasions that there's a large variability in both charges and reimbursement from provider to provider and region to region. Historically, when we've dealt with patients that really went where they were told and there was very little financial personal investment, if you will, those individuals are now going to start to make decisions with their health care based upon their wallet because they've got more skin in the game. And I think we all need to recognize and just understand that as they better understand through the education that we're providing to them, they want to know the real cost of care. And that's really where we're headed. That's where CMS is looking for us to lead and really move the industry. As an example, CMS just recently published, back at the end of the third quarter, beginning of the fourth quarter, a website that allows the public to go online and pull up an estimate or a cost of care. And they're using this as a catalyst for a new means of shopping for healthcare services. This particular tool that they've deployed, in our view, is really in its early stage. It's a very simple tool at this point. Users can key in a code or key in a keyword, and it's similar to a Google search where it will provide a list of services with that particular keyword. And it will pull up and it will show today the national average difference between an ambulatory surgery center and a hospital outpatient. And again, this is based upon the patient beneficiary responsibility. But this particular site also includes a link to specific hospitals, and when you click on the link, it provides a list of hospitals based upon the individual zip code. So we can see, as a future projection, this tool will likely move further down, and it will provide patients, consumers, at least watch for Medicare beneficiaries, what their out-of-pocket portion is going to be at your facility compared to other facilities in their geographic location. We anticipate this future is probably not too far off because CMS has this data, and they will likely move from this just being an average to being a hospital-specific estimate tool for Medicare patients. If we look at an interview and some of the comments that were made last week by CMS's administrator, we can see that CMS is truly looking for our industry to have leaders that will lead, and they're looking for our industry to not wait for CMS to put out the next mandate, but really help consumers, help patients understand the financial cost ahead of time versus finding out the financial cost after the fact. We absolutely believe we must help patients understand what the cost of care will be for them prior to that particular service. If we look at a number of references that have been made the last couple of years in terms of travel comparisons, if we can get a flight estimate, a hotel estimate cost through a website, we should be able to do a similar process with healthcare costs. And I think we're all, as an industry, moving to providing that type of estimate for individual services in fairly short order. But more broadly to your question, Enrique, I think we need to be looking at how do we take this to the next level. And our goal really should be to provide more of an Expedia-type bundle. If organizations such as Expedia can go out and negotiate contracts with airlines and hotels and rental cars to come up with a bundle payment, there are going to be organizations that will be looking to provide that true cost of care. It is our view that I think as an industry we should be moving in our local communities to help lead that direction, and just recognizing that if we don't take control of this price message, patients are going to go where they get the right information. And I think there's that opportunity for us to lead on out into the future beyond just those individual service cost estimates.
Alrighty, and then finally, for our last panelist question, I want to first direct it to Susan. What do you think will be the biggest impact that price transparency will have in the healthcare industry in the next 2 to 3 years?
Hopefully, it will push the conversation. The financial health for our patients is just as important as the physical health. And currently, the tools don't exist for our patients to use in the decision making. Like you just showed, they need some sort of a tool that will give them the bundled price. Right now, the patients are required to go out to all these different places, so they need to go get the hospital estimate, they need to go get the physician estimate. They don't know if the radiology is included. And half the time, the patient doesn't know about these different pieces. To them, it's all a surprise. They get all these different little bills coming in the mail. But at this point, I think for what it's worth, publishing the charge master at least gets the conversation started. It may not be helpful to the patient as such, but at least it gets the conversation started and starts pushing the industry towards at least coming up with something or doing something, because I think if it isn't pushed, then it'll just sit there and linger and nothing will ever happen. So I hope in the end we end up where the patients need is the tool they need to look and make the proper financial decision for their circumstances.
Alrighty, and Megan, same question.
I definitely anticipate that this is just the beginning, and there's going to be more stringent guidelines that will be placed on organizations to empower customers to make more informed decisions about where they want to receive that care and what's going to be the most financially responsible for them. I love the bundle payments, and as soon as we get to bundle payments, that goes to comparisons, right, from organization to organization, which, will drive that competition. And also force organizations to be more methodical in their pricing to ensure that they are in line with the market and reevaluate actual costs for expenditures that they're incurring within the organization for services that are provided in hopes of long-term stabilizing some kind of pricing across the various regions. I think payers are also going to have a big part of this as well, because they are definitely not very in line with one another when it comes to, certain payment arrangements.
Thank you very much. And finally, Jackie.
So 2 things, really. First, I really hope that this whole initiative is going to eventually empower our consumers to really better understand just how billing and health insurance work. So we've seen a lot of great examples today of hospitals that have put a lot of time and effort into educating patients, and you take the charge master out of the conversation, hopefully just that information will empower patients to be able to make more informed decisions when choosing their insurance coverage and also when choosing where they're going to receive their health care. Second, to kind of echo Megan, I really think that prices will end up normalizing in markets where today that might not be the case. So if hospitals want to remain relevant and they do not want to get some of the scrutiny that we've seen shown here as examples today, they're going to need to adjust their prices accordingly.
Sounds great, and perfect timing as we are now at the top of the hour, just about ready to begin our last Q&A session. And before we do that, I just want to give the results of our last poll. Again, that question was, given that patients ultimately prefer a total cost of care estimate, what is your confidence level in providing this to patients this year? 22% said very confident, 46% said somewhat confident, and 32% said not confident. So, as I'd like to certainly extend a thank you to everyone who's on the panel today, and we do have one last question in the Q&A queue, and that is from Jory. Is there a solution similar to Medicare procedure price lookup for inpatient procedures? Let's start with, Greg, do you happen to know the answer to that one?
CMS has not published something along those lines yet. It may be something they have in the works, but I've not seen anything like that. I do know different individual hospitals have deployed estimation systems that do provide estimates in a similar fashion for inpatient services.
All right, thank you very much. And you know what, I'll just work one last question in here just to close things out, and that is, what metrics do you track around price estimates? Are you tracking accuracy of the estimate, or things like how long it takes to provide the estimate once patients request it? Let's start with Jackie on that one, metrics around price estimates.
I would say both. You want to have specific turnaround times, because every day that you're waiting to give a patient an estimate, their insurance situation could change, their deductible amount might change, everything could be different. So you want it to be quick, but accuracy is key, because if you're giving out information that's completely irrelevant, then really what's the point?
For sure. And how about you, Megan? Questions about metrics that you're tracking for patient estimates?
Currently, we don't have an estimate tool, but we do track turnaround times and also what procedures are being inquired about, to see if there's any kind of trends with that, as well as who is requesting the information. We'll have more metrics to come once we get that pricing tool in place, I'm sure.
Sounds great. And finally, Susan, any metrics that you're tracking around price estimates?
We track both how long it takes to get the estimate to the patient as well as accuracy of the estimate.